Good morning, my students. Let us come to the third part of diuretics, where we'll discuss primarily the loop diuretics, the moderate ceiling diuretics, and the carbonic anhydrase inhibitors. Out of the loop diuretics, we know that the important ones are furosemide and torsemide, whereas the thiazides are already been said, divided into two halves: the thiazide group of diuretics, which contains hydrochlorothiazide, benchthiazide, whereas thiazide-like diuretics like chlorthalidone, metronidazole, and drugs like indapamide. So here in this picture, we are clearly seeing that why this red line is going up. The more you increase the dose, the more you getting the response. So that is the reason why it is called high ceiling diuretic. Whereas in case of thiazide, if you started increasing the dose, after reaching a certain value, it is forming a plateau-like line. So it is basically a moderate ceiling diuretic. If you increase the dose of thiazide, it will only increase its adverse drug reaction, nothing else. So in this picture you will see the kind of renal absorptions, reabsorptions occurs normally in the physiological system. So we can see here from here that sodium, which is being filtered, is almost proximal tubule is around 70%, and it is almost 10% in the loop of Henle. Then the distal tubule, it is around again 10 to 14%, and the excretion is only around 1%. Whereas if you look at here, the blue one is basically the water, it is related to water, and this green one is related to the filtration of sodium. So these two are showing in different tubules and in different positions how much of the sodiums are being reabsorbed. We know the pattern of excretion of electrolytes, how much of which type depends on the class of diuretic agents. Obviously, the high ceiling one will excrete or the rate of extent of excretion of urine is more with that. Maximal response is limited by its site of action. So that is being seen with different group of diuretics, and you can always combine two diuretics where especially by combining two you can combat the adverse drug reaction of the other, especially with furosemide with potassium sparing diuretic or thiazide with potassium sparing diuretic. You can always do that because they can combat each other's potassium level. This thiazide and furosemide are responsible for excretion of potassium, whereas potassium sparing diuretic will retain potassium in your body. So ultimately combination will keep your potassium concentration constant in the blood. So these are the different transport mechanism by which these diuretics are being transported. It's via channels, via different membrane proteins, via co-transport mechanism. The carrier mediated one is very important. There is a counterfeit co-transport mechanism. There also the carrier mediated transport is showing a very important role, and ultimately the water moves intracellularly in permeate segments or via tight junctions between the renal epithelial cells. Now this is a picture which will show you the transport mechanism which I described above. If you look at this, you can clearly see these carrier mediated co-transport and the other mechanisms of the transport of different ions. Carbonic anhydrase inhibitor, which is not that significant in terms of diuretics or that important in terms of diuretics, is basically work on co-transport of sodium bicarbonate and chlorine, and that is coupled to hydrogen counter transport, and it acts to block carbonic anhydrase enzyme. Carbonic anhydrase converts this bicarbonate and hydrogen to carbon dioxide and H2O in the tubular lumen, and this carbon dioxide ultimately diffuses into cell, and water follows the sodium. Therefore, this carbonic anhydrase converts carbon dioxide and water into H plus and HCO minus ions. Now, H plus is now available again for the counter transport mechanism with sodium, and sodium and bicarbonate are now transported into peritubular capillary. So, this carbonic anhydrase can catalyze reaction in either direction. It is depending on relative concentration of the substance on which direction it is going. Site of action of this carbonic anhydrase is primarily the proximal tubule. So, these things are being demonstrated here. Whatever I said in the previous slide, that is being demonstrated, that it is working in the cell as well as the same thing is working in the lumen. So, in both the sides you will see these things. You will see the reduction in hydrogen ion in the peritubular cells for sodium hydrogen antiport exchange resulting in decreased sodium reabsorption, and tubular concentration of sodium, hydrogen and bicarbonate, these are increased, resulting in alkaline urine and metabolic acidosis. And there is basically decreased secretion of ammonia in collecting duct. So, what is the significance of this? The significance is, in case of metabolic alkalosis, you can prescribe a drug like carbonic anhydrase inhibitor. The drugs are acetazolamide, dorzolamide. You have heard this name in relation to glaucoma. So, they are blocking this catalyzation to carbon dioxide. They are useful for treating glaucoma and metabolic alkalosis, as I mentioned before, and they can cause hyperchloremic metabolic acidosis from bicarbonate depletion. Now, they have certain kind of extrarenal function. As I said before, that hyperchloremic acidosis is one of the characteristic feature of this thing, and it reduces the diuretic effects. It increase ventilatory drive, and it decrease intraocular pressure due to reduced formation of aqueous humor, and that's the reason why the drug like acetazolamide and dorzolamide are very useful in glaucoma, obviously as an add-on drug, not as a first line drug. In acute mountain sickness, above 10,000 feet atmospheric concentration of oxygen is low, so the climbing experience, the climbers, they will experience hyperventilation and increased elimination of carbon dioxide, resulting in respiratory alkalosis. Acetazolamide increases urinary excretion of bicarbonate and causes metabolic acidosis, and which offers which offsets in other sense the respiratory alkalosis in high altitude. So, to prevent that respiratory alkalosis, you can prescribe acetazolamide to a person who is traveling in the mountain. To alkalinize the urine, you can prescribe this, and in petit mal epilepsy, that means the one which is not having the seizure, in that case the one which is not having the tonic-clonic seizure, in that kind of epilepsy you can prescribe this drug, but the problem is tolerance may develop. There is another epilepsy called catamenial epilepsy, which happens during menstruation, and that case also you can prescribe acetazolamide like drug. The problems are rash, allergy, blood problems, drowsiness, paresthesia, And in hyperchloremic acidosis, obviously you cannot prescribe this, and in case of hepatic encephalopathy. There are few important drug interactions which can be observed with acetazolamide and methenamine combination. The decreased activity of methenamine is observed, but these kind of interactions are not observed nowadays, whereas acetazolamide and weak organic bases, they may increase toxicity of basic drugs. So, these are in brief about the carbonic anhydrase inhibitors. We have already discussed osmotic diuretics, so I am skipping that part and coming to the aspect of loop diuretics. So, these are the drugs which are acting on ascending loop of Henle, and they are actually inhibiting sodium chlorine potassium 2 chlorine cotransporter system from lumen to ascending limb of the cells, and therefore they blocks cotransporter mechanism and retaining sodium, potassium and chlorine inside the lumen, and these things will be excreted along with water. So, what will happen? It will, and these are all high ceiling diuretics. So, as we increase the dose, you see the action will increase. So, what will ultimately happen? You will see that the patient will having hyponatremia, hypokalemia, hypocalcemia, hypomagnesemia. So, everything will be hypo, except few things like probably it may lead to hyperglycemia. So, there is some kind of little bit of metabolic problem, otherwise mostly you see the hypo part is predominant in case of electrolyte balance. Furosemide is the prime example of this high ceiling diuretic. It is a sulfonamide derivative. Beside this, there are other derivatives like bumetanide, and this is partially metabolized in the liver and partially excreted through kidney. The brand name of furosemide is Lasix, Lasix. What does it mean? It means its action is lasting for 6 hours. That is why the brand name is given as Lasix. The previous one from the same group was ethacryonic acid, which is now become obsolete due to its toxicity, especially ototoxicity. And the sulfonyl urea derivative is torsemide, which is the most potent one and nowadays very commonly used in clinical practice. There are functional criteria of high ceiling diuretics. They are effective in compromised renal function, GFR were less than 30 ml per minute, effective in altered acid base balance of the body, high natriuretic potency, it has around 25, 30, even 40%, steeper dose response curve, the more you increase the dose, more you get the effect, and quick onset of action and short duration of action. So, these things are observable with the drugs like furosemide. I will come to mechanism a little bit later. Before that, we must know what are the therapeutic uses of this kind of drugs. Obviously, they are causing greater diuresis than thiazides, but they are never being a first line drug over thiazide in case of hypertension. Rather, the thiazides are preferred. And hypocalcemia and hypomagnesemia are the characteristic feature of loop diuretics, but in case of thiazide, we are observing hypercalcemia due to some other reasons. Now, the therapeutic uses of this group of drugs like loop diuretics are in edema, like cardiac edema, that means the left ventricular failure, in hepatic edema, also in renal edema. In hepatic edema, as the secondary hyperaldosteronism is the reason, basically the first choice of drug is spironolactone. But in cardiac edema, it is a very good drug of choice, and also in renal organ, we should use this drug. Acute pulmonary edema, where the relief of dyspnea even before diuresis will happen due to venodilatation. And this venodilatation is usually occurs due to release of prostaglandins. So, by releasing prostaglandins and then followed by its diuretic action, it is giving you relief from pulmonary edema or left ventricular failure. It is used in severe heart failure, in the hypertension, hypertensive emergency, essential hypertension with renal impairment, acute renal failure, in forced diuresis in case of poisoning, while the blood transfusion in case of severe anemia. So, these are all the therapeutic uses of loop diuretics, whereas it has some kind of adverse drug reactions, and you always remember the hypokalemia, hypocalcemia, hypomagnesemia, hyponatremia. So, all hypo will be the prefix of a common prefix of different kinds of adverse drug reactions. There are few exceptions like hyperglycemia may happen and hyperuricemia. So, it is very carefully used in a diabetic patients or in patients of gout. It is also causing dose related ototoxicity when it is specially prescribed with some drug like gentamicin, which is an antibiotic. Delayed closure of patent ductus arteriosus of the infant when giving to the nursing mother. It has few drug interactions. The lithium with diuretics may lead to lithium toxicity, except the amiloride. The warfarin high-seling diuretics may increase anticoagulant action. Furosemide with NSAIDs, the painkillers, it may lead to decreased response to furosemide. The NSAIDs are having that kind of action because they are all, both of them are acidic drug. Then the GI toxicity and ototoxicity are more with ethacryonic acid, so it's almost a banned drug. Torsemide is the most potent drug which can be used in pregnancy, but very judiciously. All these preparations, especially the furosemide and this the other one which I mentioned, that one is your torsemide. These are very good drugs in case of, to treat a case of left ventricular failure. That means they are the most potent drugs, especially the torsemide part. So, torsemide is a very potent drug and very commonly used in clinical practice. Now, if you go through the mechanism of action of this drug, you will see the furosemide is a high-seling diuretic with natriuretic potency of around 20 to 25%. It has got bioavailability of around 65%. The drug is secreted in the proximal convoluted tubule by organic acid transport system, and it gains access to the site of action mainly at the thick medullary ascending loop of Henle. Now, the furosemide acts at the luminal surface of the epithelial cell and inhibits sodium chlorine 2-chlorine potassium symport system, resulting in inhibition of reabsorption of chloride and sodium. Under certain conditions, the loop diuretics increase renal blood flow without increasing the filtration rate, and therefore, when this takes place, there is a redistribution of flow from medulla to cortex, even within the cortex. For this mechanism, there was maybe an involvement of renal prostaglandin and renin release. So, furosemide, being a sulfonamide group of drug, is an inhibitor of carbonic anhydrase also in massive doses. Is a very good high-seling diuretic. It causes diuresis regardless of the state of acid-base balance, and it under compromised renal function, it's a drug of choice. Along with soluresis, that means it releases both sodium and chlorine. It causes increased potassium, calcium and magnesium excretion. So, these are the things which you have to remember regarding the mechanism of action of this drug called furosemide or loop diuretics or high-seling diuretics. They are the same thing, only the torsemide and furosemide are the examples. In forced diuresis, in forced alkaline diuresis, probably is the treatment of salicylate, that means in acidic drug poisoning, the barbiturates, salicylates, they are probably causing the poisoning, and you can use furosemide like drug. Whereas in forced acidic diuresis, for the treatment of chloroquine and amphetamine toxicity, you can use the same drug, the furosemide, that will help you in the forced diuresis. if you compare its hypokalemic effect, you will see that chlorthalidone, hydrochlorothiazide, they are having more hypokalemic effect in comparison to furosemide, mainly because of the duration of action when the drugs are used chronically. Now, from loop diuretics, I am shifting to the next second group of drugs which are acting on the distal tubule and acting on the sodium chlorine co-transport, not on the sodium potassium to chlorine transport. That drug is thiazide or thiazide like diuretics. Chlorothiazide is the initial one, and the natriuretic potency is lesser than hydrochlorothiazide, but and obviously its potency and as well as its sealing effect is lesser than the loop diuretics. It's a moderate sealing diuretics. These are not effective therapeutically when the GFR is less than 30 milliliter per minute. Rather, it is contraindicated. It will decrease GFR. Metolazone is the only exception, which is a thiazide-like diuretic, and sometimes indapamide can be given in this condition. The mechanism of action of thiazides are basically on the proximal convoluted tubule by organic acid transport system. They are secreted and then carried to the distal convoluted tubule along with the tubular fluid. Now, the thiazide diuretics inhibit the reabsorption of sodium and chlorine in distal convoluted tubule by inhibiting sodium and chlorine symport. More sodium reaches the distal tubules to stimulate exchange and potassium, particularly in the presence of renin, angiotensin, aldosterone system. Thiazides may also increase the active secretion of potassium in distal convoluted tubule. So, that is the reason why, as thiazides increases the active secretion of potassium in distal convoluted tubule, that is the reason why, in spite of blocking sodium chlorine channel, it is responsible for causing hypokalemia, and the hypokalemia is even sometimes more than that of furosemide. The effects of thiazide on urinary electrolytes are just like furosemide except calcium. It decreases calcium due to reabsorption of calcium from distal convoluted tubules. So, it will lead to hypercalcemia. So, thiazide will lead to hypercalcemia, whereas furosemide will excrete calcium and lead to hypocalcemia. The effects on blood and electrolyte and acid base balance are like it will increase bicarbonate and hence a little bit of metabolic alkalosis. The external effect can be seen, and the increase in LDL cholesterol is observed with thiazide. Hence, a patient with high cholesterol level is usually getting a drug like indapamide, if any drug from the thiazide group of drug at all given in this case, because indapamide is not changing the level of LDL cholesterol, and chlorthalidone is having the longest duration of action. It is 48 to 72 hours, and its antihypertensive property is also better than thiazide, though it is a thiazide like diuretic. It is a diuretic of choice in case of mild to moderate edema with in mild to moderate edema with congestive heart failure, reduced preload with reduced afterload over heart, increased in efficacy of heart, it reduced the extracellular volume, load of heart is reduced. So, except metolazone and indapamide, most of the thiazide diuretics should not be given or rather contraindicated when GFR is less than 30 ml per minute. In primary hypertension, it is the drug of choice. So, initial monotherapy should be prescribed in old, obese, female patients, in blacks. Antihypertensive mechanism are quite clear. It is usually given in a non-edematous condition. Reduction of ECF volume usually due to happen sallurosis, reduction of the cardiac output, and ultimately the persistent reduction of the peripheral resistance due to loss of sodium that will ultimately affect the tonicity of the blood vessels. On chronic administration of thiazide, the cardiac output returns to pre-treatment level. The ECF volume is highly less, that means extracellular volume is slightly less than the pre-treatment value, and that is only 5% less, but the antihypertensive action is usually continued. So, the antihypertensive action is basically due to the persistent reduction of peripheral resistance, not due to decreasing in cardiac output. But the antihypertensive action of thiazide is dependent on primary soluretic action of thiazide, because in anaphoric patients and in compromised renal function where GFR is less than 30 ml per minute, thiazide do not cause antihypertensive effect. So, it requires both the actions, the initial action which is primary soluretic action, followed by the action which is basically the decrease in peripheral resistance. In vitro it has been seen it do not dilate blood vessels, but loss of sodium will cause decreased intracellular calcium of the vascular smooth muscle, and this is responsible for vasodilatation. The responsiveness of vascular smooth muscles to the vasoactive substance will be reduced by thiazide group of diuretics. For the antihypertensive action of thiazide, there must be moderate salt restriction. Unless you restrict the salts, the sodium concentration will remain the same, and hence the drug is not going to be effective, whatever may be its mechanism, whether it will decrease the cardiac output or it will reduce the peripheral resistance. Again it will come back to normal unless you are restricting sodium when a person is getting thiazide. Usually a low dose of thiazide is administered. Otherwise, it may lead to, if you prescribe it more than 25 milligram, it may lead to cardiac arrhythmia. So, due to that dangerous side effect, it should be restricted within this range from 6.25 to 25 milligram. That is why it is called moderate ceiling. In cirrhosis, of liver, in renal problems, and nephrotic syndrome, acute glomerulonephritis, it can be used. Paradoxically, it can be used in nephrogenic diabetes insipidus, where the patient is having more urination. Diabetes insipidus is a non-edematous condition, and there is polyuria with very dilute urine. It is usually of two types, central and nephrogenic, that means which is ADH resistant. Now, hydrochlorothiazide is effective paradoxically for the treatment of nephrogenic diabetes insipidus. When thiazide is administered, it is secreted in the proximal convoluted tubule and is carried to the distal convoluted tubule. Now, when it is carried to the distal convoluted tubule, it blocks sodium and chlorine co-transport and causes diuresis. But after 2-3 days, there will be contraction of extracellular volume, and therefore, following this, there will be more and more reabsorption of sodium and water from proximal convoluted tubule. It is not allowing sodium to come to the level of distal convoluted tubule, and hence there is a reduction of tubular fluid volume. Now, there is a isotonic tubular fluid which is carried to the distal convoluted tubule, that is low volume and less dilute tubular fluid, as sodium cannot be reabsorbed at distal convoluted tubule due to presence of thiazide. So, what happened? The reduction of the urine volume is done. Moreover, the thiazides reduce the GFR with reduction of your thirst, and these diuretics become ineffective in nephrogenic diabetes. When the diuretics become ineffective in these diuretics are becoming ineffective in nephrogenic diabetes insipidus, but in case of central, it is effective in that manner. So, it is basically a hypothesis. If modest salt restriction is not done, monitoring of hypokalemia is recommended and supplementation is occasionally required. Osteoporosis, bromide intoxication, hypercalcemia, as I said, and that means hypercalcemia, there is always a chance of formation of urinary calculi composed of calcium salt. But because of thiazides, it will reduce urinary calcium excretion by enhancing tubular calcium reabsorption. So, you can use thiazides in case of hypercalciuria. The common adverse drug reactions are hypokalemia, may cause sudden death due to arrhythmia, hyperuricemia may lead to gout, hyperglycemia lead to diabetes mellitus, hypercalcemia, hypophosphatemia, then the hypomagnesemia, sometimes it is also increasing LDL cholesterol, low density cholesterol level. So, that is the problem of this group of drugs like thiazide. The drug interactions, a few of them are already been discussed in your drug interaction section, especially with digoxin. It may increase the toxicity of arrhythmia, and it reduce renal clearance of lithium, and with quinidine it may prolong QT interval, and it also inhibits the or reduce the efficacy of prostaglandin inhibitors, that means that of NSAIDs. So, these are the common problems which we may encounter in case of the drugs like thiazides or thiazide like diuretics. So, with that, we are coming to the conclusion of our presentation on diuretics, just by showing you once more, reminding you once more about regarding the name and the types of diuretics. The potassium sparing one like aldosterone antagonist, spironolactone, triamcinolone and amiloride, which has been discussed in the previous presentation, and the carbonic anhydrase inhibitors is uses, the clinical uses, then followed by the loop diuretics, where you can give it in mostly in hypertensive emergency, never being a first line drug here. Thiazides are always preferred, but in pulmonary edema due to venodilatation and the release of prostaglandin followed by its diuretic action, it is a preferred drug. And in case of renal failure, you can always prescribe the drug like loop diuretics. So, these are all the therapeutic uses of loop diuretics. In case of thiazide diuretics, you see essential hypertension, congestive heart failure, maybe with furosemide, renal calculi, nephrogenic diabetes insipidus, and the mechanism is being explained, that may be given in your exam. The chronic renal failure, except if the GFR level is less than 30 ml, then probably it should not be prescribed, and in osteoporosis because it is causing hypercalcemia. So, these drugs are being discussed as a part of the topic diuretics in the last presentation. So, with this I am concluding by saying that the last group of diuretics, which is the mannitol, is not commonly used for its diuretic purpose, but it has its other uses like in raised intracranial tension, in raised intraocular tension, that means acute congestive glaucoma, it has its own uses, and in heart failure, this mannitol is absolutely contraindicated. So, with this I am concluding my presentation.